Hello, this is Anne DeGheest. It's the second video. It's my clinical update on May 28, 2021. I hope you're all doing well. We're going to talk about the fact that unvaccinated people are still at risk, and some really interesting data showing they're at risk at the surge level. So we want to do a deep dive on that. New data have emerged on long COVID. 73% of people who have had COVID have some persistent symptoms. I will do a deep dive on strain and variants and tie that to vaccine effectiveness. If you haven't seen my first video, please see it after this one. We'll talk about the fact there's probably an extra 7 to 13 million excess death. In addition, the 3 million has been reported. There's a surge in South America. Good news, India and Europe are slowing down, and US is doing fantastic. And so please take a look at the first video. So this is a cool picture of the virus. You can see it in the little green dots. That's surrounding this cell in orange. This thing is really tiny. That's why it's floating in the air, and unfortunately that's the way it's spread. So to give an idea, this is a really electronic microscope picture there. I thought it was really cool. So let's go to some of the interesting data. So this was an analysis that showed that COVID continues to rage across the unvaccinated. And the way they did that, this is using, for example, Washington State, is that they look at the people who are vaccinated versus people who are unvaccinated. They were able to separate the caseload. And what they're showing is that the infection rate and the surge is at the level that we had in January. So that unvaccinated seniors are 11 times as likely to get hospitalized than seniors who got vaccinated. So that's a huge delta. And for unvaccinated people aged 45 to 64, the chance of COVID hospitalization is 18 times higher. So, my objective today is to explain to you why you need to get vaccinated, because the risk of the vaccine is very little compared to the risk of getting COVID and the damage it creates, as well as the long COVID. So they did an analysis by different state. And you can see Oregon, for example, there, is having a B117 surge. That's why in the first video, I've shown that Oregon is flaring up a little bit there. They're having a pretty big surge coming from that UK version that's spreading across the state and in the upper part of Northern California there. Maine, Colorado, Michigan, and Washington State, the unvaccinated rate of their population is double the one from the national rates, and that's why you're seeing a higher incidence of infection rate there. So they clearly, what they're saying is to say, listen, if you're unvaccinated, you're still at risk as bad as it was during the surge. Do not assume that because people are vaccinated around you, you will not get the virus. You could get the virus. The death rate, they did a similar analysis showing the mortality of people who were vaccinated versus people who were not vaccinated. And you can see there's a big delta there in the mortality rate. So it is unfortunately a serious risk that still exists. Hospitalization is also tied to this. DC and Michigan have a rate that's twice as high as the adjusted national rate of hospitalization. Pennsylvania, Maryland, Florida, and Rhode Island are 50% higher, and this is all tied to their vaccination rate. So, you're still at risk. Don't assume we're not other words. Please get vaccinated. So I want to take a little step back and kind of go back to say when COVID hit, we really focused on that acute infection symptoms, which all the statistics as you share. And then we learned that the virus kicked in this inflammatory immune response, and that has long-term consequences. And now we have learned that in certain cases, most of the key organ in the body, the brain, the heart, the kidney, all of that can be damaged from this inflammatory response of blood clots. And then you, of course, if you had a stroke or heart attacks, you have clinical sequelae. But then there's this emerging area that we've been talking about for several months now called the long COVID, where after you have the infection, and most people are mild or asymptomatic there, you start developing persistent symptoms 3 to 4 months later. So let's do a bit of an update into what that is. So around 10 to 30% of people who have had COVID, regardless of age and regardless of severity, will develop long COVID. Most common fatigue and most common symptoms are chronic fatigue, intense fatigue. I mean, to the point that, you go up and down the stairs and then you just have to take a nap for a couple of hours. You have what's called post-exercise malaise. So when you tell these people to go exercise, they'll feel better. That's the worst advice you can give them. They need to really see a professional and get titrated rehab to get them back in shape there, because otherwise they crash and burn and they basically have a setback that's quite significant. They feel acute chest pain. They have cognitive problem and brain fog. It's really like a concussion. It's not like dementia. They just cannot think straight. They all complain of shortness of breath. Some have lost taste and smell. It takes months to get it back. And they have what's called POTS, that if you're sitting and then you get up and your heart rate goes, let's say from 60 beats per minute to 160 beats per minute, please go see a doctor there. That's one of the way you can test for that problem there. And they have sleep disorder and a lot of mental health issue. We have learned that Ebola, Zika, and the original SARS were hiding. They were basically hiding in the salivary glands or the sexual glands and all of that, and they were continuously festering the body in spreading the virus. So they had this pocket where they were hiding from the autoimmune system. It's pretty much coming more and more clear that this is a neurological injury from head to toe. The autonomous nervous system gets attacked, and that's why it's no longer controlling the heart rate and the blood pressure. And then you develop the sensitivity in all your nerves, and that's why it feels like shortness of breath, when in reality, the pulmonary functions are fine. And unfortunately, we don't really have a good way of diagnosing and measuring your nervous system. And that is a problem there, because the physicians, in 90% of the case, cannot find a diagnostics that measures something that's unusual. The data just came out yesterday from Stanford, and showing they did a massive meta-analysis on 45 studies with 9,000 patients. And they showed that 73% of patients who have had COVID several months later still have one persistent symptoms. Most of them have 10. Shortness of breath being number one, chronic fatigue, and sleep disorders there. So it is a serious risk. Not only it's not the fatality rate we're going to learn in, it's really that long COVID that's the serious risk of this disease. What are the cause? As I discussed, it's a damage of the nervous system. It could also be this dormant autoimmune virus that get activated as your immune system drops. You may have some dormant autoimmune disorders that kicks in and unfortunately can no longer be controlled. And people may have had post-hospital complication there. There could be some issue there where you had blood clots. And we know the virus is toxic to the heart, the brain, the kidneys, a whole bunch of areas there. So it is a really nasty thing. That's my definition. And then the last one on this is that another paper also came out showing that most people develop some neurological issue. Please get vaccinated. So let's talk about vaccine. Novavax, good news. They finally showed their results for on phase 3 results between 18 to 84 years old. They have not been approved yet anywhere, but they're going to be submitting for emergency use authorization there. They show an overall 89% efficacy against COVID, but if you split it between the variants, because remember, Pfizer and Moderna got their efficacy data based on the prior variant, not the new ones. They show 96.4%, which is as good as Pfizer and Moderna. And then they show like the other mRNA, a lower efficacy against the B117, which is the UK variant there. The great news is that they show no hospitalization or death. And they've promised 100 million doses to the US and $1 billion to COVAX. COVAX is this organization there that is trying to get vaccine to low-income countries that's being subsidized by the richer countries. So the other thing that's interesting about them is that they are participating in this mix and match clinical trials, which I'll talk more about, where they could be maybe a third booster for us, because you're going to see that you may not want to get the same firm for your third boost coming up. And so there's trials going on that subject there. Moderna, as you probably saw in the news, has submit a request for approval to the FDA for the 12 to 18 years old. And that's great, because in addition to Pfizer, that will give us the volume we need to vaccinate as many kids as possible. And they show huge results. I mean, 100% efficacy after 14 days. So that's great. So breakthrough case. Well, if you get the vaccine, can you still get COVID? This is what's called a breakthrough case. The data has come out from the CDC saying that the risk of getting it is 0.01%. This is like even better than whatever the clinical trial shows. So it is really effective. And the CDC reported that study for people who had the vaccine between January 1st and April 30th. So it's pretty, recent, fresh data. They had 10,000 cases out of 100 million people got vaccinated. 63% were women, 27% had no symptoms. They just did kind of an analysis there, and they got caught with a positive CPR test, maybe in an airport and other locations there. And only 10% got hospitalized. We did have, some death, but they were mostly elderly people. And 5% reported case at variant analysis, and those show that most of these people who got infected had the variants of concern. And that's the California variant, the UK, the Brazil, and the South Africa. So again, the effectiveness of these mRNAs is fantastic, but it is lower, a little bit lower for some of these variants. So we're going to spend more time on the variants. The mix and match COVID vaccine, there's several trials going on in the US, in Europe. And what they want to do is that you do, let's say, Europe has a concern with AstraZeneca, which, if you remember, has some of this blood clot issue there that people are worried about. So they are doing the AstraZeneca, which is based on a harmless chimpanzee adenovirus. And then they want to give the second dose, which will be a Pfizer or a Moderna. Right now, Pfizer is more available in Europe than Moderna. And they started thinking that it may be beneficial to have a different third dose, because that will increase your breadth of coverage, because all these vaccines are slightly different there. So I would say it's a high probability that if you're Moderna, you may end up with Pfizer or some other vaccine, for the booster. But we'll know more after these trials, continues. So mutation versus variant versus strains. I talked about this a month ago, but it's complicated, so I'm going to talk about it again briefly there. So mutation is a change of the RNA of the virus there. And the RNA is kind of this very sloppy product there that duplicates itself, and it basically screws up at times, and quite often. And that's what we call a mutation there. So for example, N501Y is one of the things we're worried about, and that has a higher binding affinity and therefore makes the virus much more contagious there. So a variant contains several mutations. So a lot of what we call the UK variant, for example, they have 2 or 3 mutations. Typically, one of them increased the infection rate, and the other one decreased the effectiveness of the virus in the way it binds. And a strain is when there's such a mutation there that it changes the physical property of how the virus impacts the body there. So that's kind of the terminology there. So you have the RNA there that basically continuously duplicates itself. It makes a mutation there. Several mutations makes a variant. And then if they really start to be a dominant there, it becomes a new strain. And then to give you an idea, you may have heard this alphabet soup, which is the N501Y, which is the one we really worry about. And that's basically saying that the amino acid asparagine has been replaced with tyrosine, so the N and the Y, at the 501 position. Okay, so that's the way that works. The reason why we worry about that one, this is the one that's in the UK and the South Africa and the Brazil. This is the one that is creating some of this surge in some areas. The other one that we worry about is the E44K, and that's the one that decreased the effectiveness of the vaccine. And it is so bad that AstraZeneca doesn't work in South Africa with the B1351, and Sinovac also failed in Brazil. And that may be one of the reasons why there's a surge in South America there based on the type of vaccine that they're having and the effectiveness. And we know it is drastically impacting Pfizer and Moderna. For that mutation. So let's take a bit of a deeper dive. So the B117, which we call this as the UK, the way that works, why did they come up with these strange numbers? So the Chinese root was the A, and B was the first major mutation there. And then the B.1 was the one that came out with the Italian outbreak a year ago. And B117 is this continuous mutation there that has that famous N501 mutation there. So that's the way they structure that. When this thing becomes too much of an alphabet soup, then they create a new number like a C1, for example, because otherwise it gets too long. So that's kind of the logic behind that. So let's look at this alphabet soup. You can see that B117 has taken over the US. It's pretty much the dominant variants in the US. P1 is also getting bigger, which is not good because we don't want the Brazilian one. We know the vaccine is not as effective there. And then with this B1526, is kind of seems to be kind of controlled a little bit there. So these are the variants that are pretty much now dominant in the US. And I think what we need to keep in mind is that in a period of 3 months, we now have seen this over and over again. You have a mutation that comes and then takes over the whole virus landscape. So we need to be careful with the mutation not coming back and hunting us in the next 12 to 18 months. So to give you an idea, so this is a very interesting graphic that tracks mutation by countries there, and this is probably one that you want to look at. But the N501 is the one here, and you can see that's the one that came from the UK, starts spreading to the rest of the world. And here's this new one, the green one. We'll talk more about that one in a minute there. And you can see Germany, how quickly there, in a period of a few months, that that mutation became dominant in Europe. Now that green one, unfortunately, is India. And we know that India is having a very nasty mutation that, again, evades some of the increasing infection rate for sure. And then in some type of vaccine, decrease the effectiveness of it. We'll talk more about that. But here's an issue. India, is very dark green there. Look at Japan. We know we have an issue with the Olympics there because they're having a surge in Japan. And it is that Indian mutation there that suddenly took over. They had done a great job dropping the traditional virus, and then somehow this thing just took off like a rocket. You can see in France and Belgium is still the B117 that they're dealing with. So what is the worry? The worry is that we have this B1617, which is this new strain that has come up, it becomes dominant in the UK and India. That's that new green thing we just saw about. And the worry is that, here's the India curve, here's the UK curve, and there's a bit of an uptick there we see in some states with that new mutation there. So that's a bit of a worry there. And so I want to show an analysis that they did in England. And they look at that 617, which is that Indian mutation. Look what it did in the last 4 weeks since I talked to you there. It exploded some part of England, especially Bolton, which is kind of a hot area there. They were nicely controlling it. They were doing great. And the thing just took off like a rocket. So these are the things we worry about. And so in UK, they show that the infection rate was in the younger population because the good news is the vaccine is working with the elderly, but the younger population, unfortunately, this mutation there is much more infectious. And so that's something. The good news, the mortality rate is low because these young people are so much stronger, but it's still spreading the virus. And of course, we all talk about the long COVID risk to be a real risk. So let's talk about how effective vaccines are against the key variants. So just as a reminder, the B117 is what we traditionally call the UK, the 351 is South Africa, P1 is Brazil, and this infamous 617 is the Indian one. And the good news is that they've done lab studies, they've done randomized clinical trials, so we're getting some quality data to see what's the effectiveness. So let me kind of review some of it. So several papers have been published recently in New England Journal of Medicine. It showed that the Pfizer vaccine is effective against the British and the 351 variants. And this was done in Qatar. But it showed that getting a 2 doses is important there because they really didn't get the protection until they get the full doses. And the good news is that, the South African version dropped the effectiveness from 90% to 75%. So it's still effective, but still a drop. So you still may be at risk of catching it there, where it is working against the UK variant there. So therefore, in the US, since we're still dominant on the UK variants, we should absolutely vaccinate as many people as we can, so not to give a foothold to that South African or that Indian mutation to take over part of the US. So another data came out from the England, where they showed that the household transmission drop by 40 to 50%. So if one person is vaccinated, another person is younger and is unvaccinated, it drops the viral load in such a point that even if you are a carrier, like a younger child, you decrease the infection rate drastically there. So it's not only protects you, but also decreases the transmission rate. Data just came out from Public Health England 2 days ago, and it shows that against the India mutation, the one we really worry about, Pfizer has 88% efficacy, but AstraZeneca dropped to 60%. And this is the important point. The vaccines are only 33% effective 3 weeks after the first dose. So you have to get that second dose against that Indian variant. Remember that Indian variant, that green color I show you, that's starting to spread and hopefully doesn't take over B117. The good news is the Pfizer is very effective against that UK virus. It confirms the other data we just saw. And AstraZeneca is not as effective. And that's believed because there's a timing issue. At Pfizer, you can get your full effectiveness 2 weeks after the second dose. The data is starting to be clear that AstraZeneca takes longer to build the antibodies. And so these were tested at the same time. And so the AstraZeneca may not have had the full time to build the antibodies, but that still means you're at risk during those periods, to still capture these mutations. So some good news, CDC just came out today saying that a fully vaccinated teenager can go in a camp without having to wear face mask and having physical distance, which would clearly have been an issue. Kids who are not fully vaccinated or unvaccinated still need to wear face mask, and especially indoors. So if your kids are planning to go to camp, try to get them vaccinated if they're above 12 years old, because that will probably be very effective for their experience there at the camp. School ventilation, a very interesting report just came out from Johns Hopkins. It's 46-page report. So if you're a mom that's active with the school, you may want to download it. I'll put it into one of the link on YouTube. And what they show is that you have to really bring outdoor air as much as you can. And you really have to flush this COVID across the airflow here. And of course, you may make sure that you may want to put a child-safe window fan, to increase the airflow if there's not enough wind. You should upgrade all the air conditioning system with the filters up to the level of MERV 13, which captures, these particles. Most of these schools are old buildings there, so they may not have enough circulation there. So use portable HEPA air filters. You can get one for $300 to $500 that creates enough circulation in the room. And then you should turn the air conditioning on all the time so it's not auto, so you continuously blow the airflow. So these are easy things that can be done, because remember, we're not going to get vaccine for the kids who are less than 12 years old until next year. So we really want to do as much as we can in the fall to protect them. Also, this is interesting, they recommend to stop using chemical foggers or any air cleaners, except for the filters or the UVs, and stop doing these deep clean days, because you basically bring toxic products everywhere there. That doesn't help. So just be aware that just came out today, and if you're involved with the school district, please download it. So please stay positive and get vaccinated. I hope you enjoyed this. We may move the date for the next one, which is right now targeted for June 25th. And depending what the news is, we may move it 1 week before or after. So please, subscribe to the YouTube and you get notified. Stay healthy, and hopefully we'll see you in a few weeks. And please get vaccinated. Thank you.